Thank you, Sue, and thank you for the lovely introductions. And on behalf of myself, Denise, and Emma, we just want to say how happy we are to be here this evening and contribute to this really important series. And it's an area that's gaining momentum and interest, particularly in our midwifery community. So we're very grateful to contribute. Our topic tonight is, as you said, genomics and stillbirth. So we thought it was really important to kind of just pause and reflect at the beginning of the session, and to allow people to think about perhaps their own experiences. And we understand that certainly because of the incidence of pregnancy loss, there'll be a huge proportion of people on this call this evening that may have been personally affected by pregnancy loss or stillbirth, whether it be themselves or a loved one, or even for our colleagues working in this space who may have encountered particularly traumatic experiences. We know it's difficult to process emotions around this, so you've already mentioned that, how we need to make time for ourselves to process. And we just want to reinforce that and say, for people who are perhaps finding it difficult or challenging to process thoughts and emotions around pregnancy loss, particularly stillbirth, there's a wealth of help and resources out there. And Emma's going to really go through some of those resources later. So our key message is to be kind to yourself, and you don't have to do this alone. So I'm just going to give an overview of the aims of our session. And firstly, we're going to look at the incidence or the data around stillbirth. We're particularly going to focus on the recent Embrace report, which was published last month. So it's a really up-to-date kind of snapshot of where we are, just to get a sort of an assessment of how the land lies. Hopefully, we're going to be raising awareness of the impact of genomics in stillbirth, and particularly looking at it from the patient perspective through the lens of a case study that Emma's going to share with us a bit later, and really to see what patients want or experience from the process. And to do that, we're also going to describe current clinical practice for genomics around particularly unexplained stillbirths, where parents don't get answers to why this devastating event has happened in their life, and really just to ensure that patients are getting access to good service and good testing. So we're looking at particularly the ONS data. And it's important to reflect on the National Maternity Safety Ambitions that were published in November 2015, with the target or ambition of halving the stillbirth rate from 2010 and to achieve that figure by 2025. And although there has been a decline in the rate of stillbirth and neonatal death since 2010, unfortunately the data has stagnated. And you can look at that graph in front of you, where you can see the line is sort of quite nicely decreasing, and then it sort of levels off. So unfortunately, we're not going to achieve that target as set back in 2015. And sadly, experts have calculated that not meeting that target has meant that approximately 2,500 babies will have sadly lost their lives by not meeting that target, which is devastating. So we're going to just focus a little bit on some of the highlights from the Embrace report. And as I mentioned, many of us working in maternity or an interest in health within the UK will be familiar with this report. It's an annual report, which is sort of a snapshot, a state of the nation, if you like. And we're going to look at some of the key findings around baby deaths. So you'll see the graph to the left, and we can see this sort of downward trend, which is great news. It's 23% lower than 2013, but again, not at the pace that we'd hoped, not at the decline that we had hoped, but there is some improvement when you look at the overall rate of stillbirths. And thankfully, across all of the nations, we've seen a decrease in those numbers, so that is reassuring, but as we said, not at the pace that we had hoped. I think important to point out, and data that we won't be surprised to see, sadly, is that stillbirth rates remain the highest among babies born to mothers living in the most deprived areas. And when we compare that figure on the graph on the right, it's quite staggering, the difference. Not surprising, unfortunately, we know that deprivation is a significant risk factor. And that's even taken into consideration that we have seen a drop of 8% in this rate, but it's still significantly higher than the least deprived communities in our country, in the UK. Also, sadly, we will not be surprised to see these kind of statistics. We know that, sadly, Black babies are still more than twice as likely to be born stillborn compared to white babies. We have seen improvement. We remember the start of the campaigns, 5 times more, and lots of groups really passionately bringing this important information to the forefront of maternity care. We have seen some improvement in both Black and white babies, but disturbingly, looking at this chart, we're seeing an increase within Asian baby community. We don't know why at this point, but there's certainly something that's continued to be explored. If we look at the common causes of stillbirth, actually these have remained relatively unchanged, and perhaps it's not surprising as midwives and obstetricians or women working in, or men working in maternity space, that main complications that affect the placenta, the cord, fetal health have, in fact, as I said, remained unchanged. But what is concerning is the huge percentage of unknown causes, and this always comes as a shock to me and all of us working in this space, that still for a large proportion, over a third of cases within the UK, we still do not know why stillbirth happens. The data varies globally. In some countries it's much higher, and that may be because of intervention and surveillance and testing, but within the UK we still don't know about a huge proportion of our women and birthing people who experience stillbirth. And there's some of the key highlights from that report. There's a lot of really interesting reading, a lot of very relevant reading. And if you want to get a bit more information, a bit more granular detail, I suggest you just use that QR code. So as we've mentioned, this huge percentage of unknown causes, and I guess the question this evening for us as experts within this field is, can genomics help? And before we really explore that in more detail, Sue set me the task of explaining this in simple terms. So I'm really going to try in about 1 minute. So we're really familiar generally with the term genetics. So we know that our genes is how we transfer traits and conditions down from generation to generation. We kind of got a good handle on that, haven't we? And most people working in healthcare have an overview of what genetics is. Genomics is blowing out that picture, opening that lens, so that it's encompassing not just the genes, which are the protein coding parts of our DNA, but it's also encompassing a huge amount of other DNA that we think previously was called junk DNA because we didn't think it did anything. But of course now, because of new technology and sequencing technology, we understand that this DNA actually plays a really vital role. It switches genes on, switches genes off, and really has an impact on our health and our predisposition to disease, for example. And genomic medicine, encompassing this information, has the potential to have a greater understanding of how our bodies work, how our genes interplay, what switches them on, what switches them off, and also how we can personalize medicine. And we talk about that on maternity, don't we? And we will talk about that a bit more. But using this technology gives us the opportunity to harness information that improves outcomes for mothers and babies. So how can genomics help? Well, Emma's going to talk a little bit to this, but I think it's important to know that genomics can pinpoint genetic abnormalities. It can help us inform pregnancy planning. It can help us planned for future pregnancies. And Emma's going to talk to the model that we use in the autonomies of Rainbow Clinics, how to manage these pregnancies. But also it's to give answers to parents, you know, for going through such devastation, and to be quite simply told we don't know why is really difficult. And we know that these parents aren't going to just get over it. But what we need to do is make sure we uncover any information to ensure that if there is a genetic cause or there is something in their family history that we can identify and help manage the next pregnancy. This is really important information. So I'm just going to hand over to Emma now, and she's going to talk to a little bit of some of this research. Thank you, Emma.
Thanks, Tina. So as Tina's just said, having the cause of a stillbirth identified can really help families to try and find closure, alleviate some guilt and shame, and support decisions about pursuing another pregnancy, including planning for next pregnancy as well. Now, we know the majority of stillbirths, about 81% of stillbirths, they do occur in women with no apparent risk factors. However, as midwives, obstetricians, student midwives, we're all aware of the modifiable risk factors for stillbirth, such as smoking and alcohol. We know that smoking increases the risk of having a stillbirth kind of between 1.3 and 1.6 fold, and alcohol between about two to 3 times increases that risk. But really interestingly, having had a previous stillbirth increases that risk 5-fold. So these families, when they have previously had a stillbirth, they're at a huge increased risk of then going on to have another stillbirth in a subsequent pregnancy as well. So can genomics help? It's really important to take into consideration that pregnancy loss, to try and pinpoint genetic abnormalities, and that'll help inform future plans for that next pregnancy. Like I said before, it can sometimes provide emotional closure. We sometimes get answers, but again, it's really important to have that open and honest conversation with families that sometimes we actually don't find a cause and we don't find an answer. And that can be a really challenging conversation to have with families. And it's important to then discuss their thoughts, their feelings, and more importantly, their expectations as well, and then truly provide tailored care into that next pregnancy. So thinking about this, the Rainbow Clinic model of care was designed on the back of these considerations and these thoughts. And there was a study published in 2016 looking at pregnancy experiences of subsequent pregnancy after loss in the UK. And really sadly, only 40% of UK hospital trusts actually had a written hospital guideline to support the care around pregnancy when they'd previously sadly lost a baby. And really shockingly, almost 52% of families, they really just didn't feel as though they were well informed going into that next pregnancy. They didn't feel prepared for that pregnancy after loss either. And so again, that's kind of where the Rainbow Clinic model of care stemmed from. So we started in 2013 at St Mary's in Manchester, and the model of care was designed by Professor Alex Wiesel, and we have now grown to a much larger team. We run a Rainbow Clinic every Thursday. We have a full scan day, and in our last year, we cared for 500 families who'd sadly lost a baby, and then we're going through that subsequent pregnancy after loss. We offer the postnatal debrief usually about 14 to 16 weeks after their pregnancy loss, where we really do set the plan of care as to what's going to happen, talk through investigations that they've had previously, and make sure they really feel as though they know what's going to happen in that next pregnancy, where to go when they're pregnant, and what to expect more than anything. We provide continuity of care, so it's a very small team, as I said earlier. They don't have to retell their story over and over again, and they have our contact details to call us ad hoc for extra reassurance, extra appointments if they feel as though they need to come in. We work really closely with fetal medicine unit and the genetics department as well to truly provide that tailored and individualised care for families. So we felt it was really important to look at a case, look at a family that has been cared for in Rainbow Clinic, and really try and bring alive this idea of what we provide tailored care for, why it's so important for families. So in this case study, Sarah and John, we're going to just go back to their initial pregnancy and just talk a little bit about that pregnancy first before we talk about the Rainbow Clinic care that we offered. Their early antenatal care was very uneventful. They had a normal 12-week scan, a low-risk nuchal screening scan, but came in for their anomaly scan at almost 21 weeks, and there was a query whether there was some form of brain anomaly found at that scan. A couple of days later, the family were referred into the fetal medicine unit, and again, it did confirm that there was some form of abnormal brain anatomy. And fetal medicine unit queried whether there was some a Dandy Walker malformation, and they were offered a fetal MRI at that point. There was quite sensitive conversations had around what the families wanted to do, whether they wanted to continue with the pregnancy or they were given the option of a termination of pregnancy at that point. And the couple were really conflicted about what to do, kind of back and forward, speaking to local midwives and fetal medicine unit, and really unsure about the best decision for them. However, sadly, at 24 weeks, Sarah had reduced movement and came into triage, and sadly, a fetal death in utero was confirmed at that point. Sarah had an induction a couple of days later and went on to have a normal delivery of her baby, and her baby was on centile 52 at birth. The couple decided to decline a post-mortem. However, they did consent to placenta histology, and they consented to the cord to be sent to cytogenetics. Now, really importantly, the consent process for sending the cord to cytogenetics is a verbal consent that is taken within the couple of days of baby passing. There's no written consent that we take at that point in time. And the couple felt really frustrated over the multiple conversations that was had around investigations and what was going to be sent where following their pregnancy loss. The couple had a postnatal debrief in Rainbow Clinic for 14 weeks after the loss, and a normal microarray result was given, but the family felt really upset as they thought whole genomic sequencing had been performed when actually this wasn't the case. Just a little side note, this book here that's just illustrated, The Pregnancy, Baby Loss and the Grief Journey, is a really powerful book that we often signpost a lot of our families to. It's illustrated beautifully, and it really helps families navigate that emotional journey and that grieving journey of what is normal after a pregnancy loss. And so if anyone is unsure and feels as though they need some support to help their families, this is a brilliant resource that's been designed by the University of Bristol, along with some parent involvement. It's a fabulous resource to signpost parents to. The couple were referred at the postnatal debrief into the genetics department, and were made aware that there was probably about a year waiting list at that point. And then, unsurprisingly, as often happens with our Rainbow Clinic families, the couple were pregnant 8 months after their loss. I did speak to the couple about their thoughts and their feelings around genomic testing, and I thought these quotes were really powerful to just really show how they were feeling and how they were thinking about it. They used words like frustrated, I had no answers, it just felt too long to wait. There was more waiting and more testing, and they, at the time of being of losing their baby and having those discussions around investigations, Sarah openly said to me that she really didn't see the reason for needing to have these testings undertaken and what the purpose was. And it's only afterwards, 11 months after the loss, where she's now able to look back, she can really see how important they are to inform this current pregnancy. So I suppose just there, it's a little pause for thought and just taking into consideration this family and this case study. And what was really striking to me, even as a Rainbow Clinic midwife and working in this field day in and day out, was I felt as though I had a really good handle on genomics and being able to talk to families about it. But actually, even just writing this presentation and talking to both Tina and Denise, it's made me realise I've got real big gaps in my knowledge and real areas where I need to go back and really focus on what we are actually talking to women about, to be able to feel comfortable and confident explaining these investigations and make sure these families are 100% sure about what they are consenting to. So as we can see here, parents seek investigations to understand why their baby died. It can support the grieving process. It does gather useful information for future pregnancies, and it helps inform that. And really interestingly, and I suppose we see this in Rainbow Clinic, families feel really invested in research and they really want to contribute to research to try and prevent other families from going through the worst possible thing as a parent you could go through. So as you can see here, post-mortem placental histology and chromosomal analysis does give us a huge bank of evidence. We get a lot of findings from the placenta, and that can then inform future pregnancies, thinking about medication changes if that's something that we need to add in for that next pregnancy. Post-mortem can sometimes discover potential fetal anomaly, which may have not been detected on ultrasound during the pregnancy. And that can then lead to a full MDT discussion as to whether we need to consider further genetic testing. And I suppose a little side note, it's really important to consider that ultrasound is only as good as the tools that we have, and it doesn't detect all anomalies. So for example, if we have a lady that does have a raised BMI, or baby's in a difficult position, she has fibroids, it can sometimes be really tricky to detect that anomaly. And then it's again managing those expectations and those feelings, those thoughts that the parents have as to why that wasn't potentially detected antenatally. So I'm just going to hand over to Denise now. Sorry, Denise, cutting you off.
Emma. So in a way to try and standardise the offer and provision of genomic testing in England in all areas of healthcare, we have something called the National Genomic Test Directory. The one here is for rare and inherited disease. We also have one for cancer care too, and it contains the funded tests currently available with the associated R code or test request code. It sets out who's eligible for testing and which specialty can request them. And one of the common tests that are performed after a stillbirth is the R22, which is for a fetus with a likely chromosome abnormality. And the eligibility criteria for this test includes where there's been a fetal loss that's suggestive of a chromosome abnormality, or a third trimester. And I've just altered this time frame to 24 weeks for clarity. So a loss from 24 weeks of an intrauterine death or stillbirth in the absence of any other likely cause, like an infection or abruption. So let's look at this test in a little bit more detail, because I know from working with a lot of midwives, we talk about genetic testing and offer genetic testing to families, but what does that actually mean? So the R22 can be broken down into two parts. The first part is the chromosome analysis, or the QF-PCR. The Q stands for quantitative, or I just remember it as quantity. So basically, it looks at the number of chromosomes that are present. And you might remember from biology classes, GCSE or whatever is your equivalent, that our chromosomes are inherited in pairs. We get one set from our mother and one from our father. So by counting the chromosomes, we can identify when there's a atypical number of chromosomes in a cell, and this can be known as aneuploidy. So by looking at the number of chromosomes in the cells, we can quickly identify if there's an extra or missing chromosome. And we're quite familiar with Down syndrome or trisomy 21, and this is where the baby has an extra chromosome on pair 21. So that's the first part of the test. That can be done quite quickly. And the second part of the test is the microarray. Now this is a little bit more of a detailed test on the chromosome, and it looks at extra pieces or missing pieces in the chromosome. And this can be known as microdeletion or microduplication. It can also pick up sometimes if parts of the chromosomes have been swapped over in an unbalanced way or an unbalanced translocation. And we know that too much or too little genetic information can cause problems in the growth and development of the baby, and this can result in stillbirth. So not all these changes in the chromosomes can be seen or are expressed visually as the phenotype, and so they can't always be seen on ultrasound scan. So this is why genomics can help to add to the information that we provide to families. There are limitations to the test. The chromosome microarray won't identify all genetic anomalies. So it's really key that the conversations we've had with families, we never say that the chromosome test or the genetic test came back as normal, because there's no such thing. The arrays can't detect smaller changes or mosaicism when the change is not present in all of the cells. And it also may identify variants that we don't know the significance of, or that might not be relevant to actually why we were doing the test in the first place. There's also a chance that the sample might not give us a result. Sometimes the cells just don't grow and the lab really can't give us a result. And that's so upsetting for a family. But again, if we've not made them aware of that before the testing, it's a very difficult conversation when you're trying to provide some results for that family. And then we have the next level of testing. And I'm not going to go into too much detail. I'm very conscious of time, and also it might make your brain hurt because it does me. But there are more in-depth levels of testing that are available. And the one I'm just going to pick up on is whole genome sequencing. And this is where we can look at not just the protein areas, we look at the whole of the DNA or the genome. Now, the reason this is significant is because a lot of the time, midwives and parents expect that this is the level of testing that's been done on their baby, and it isn't. This is a very specialised test. It requires a multidisciplinary team to actually review the clinical situation, and it's done on a case-by-case basis. And the testing, as I mentioned, is in the National Genomic Test Directory, and there are quite a few tests that can overlap. So it's not our gift as midwives to be able to offer this necessarily, but we need to be aware that there are other tests that might be suitable for that family, depending on their clinical situation, but to really reach out to the multidisciplinary team, which is your clinical genetics team, your obstetric team, your fetal medicine experts, really involve that MDT to get the right information for the family. The parents also have to provide informed consent, and this often involves a record of discussion and a signed signature or a verbal signature on a consent form, so that they know exactly what they've consented to, and they receive a copy of that result of that form. For most of the testing, there is advised that we test in trio. Now that means the mum and the dad and the baby. Now, this is often okay, but in some situations, obviously, we don't have one of the parents available to be tested. So some testing can still be done, but again, it's being really mindful of the level of testing that we can offer. And as midwives, we're trying to support families going through this. The wait time for the results can be every week, feels like a month or a year to these families when they're waiting for the results to come back. So to be able to know the turnaround times, which vary from different regions, is really important to know how to help support the families while they're waiting for the results. So linking in with your local team is really beneficial. These are just some papers on further testing opportunities that may be available depending on the clinical situation, and really starting to look at what's the chance of us being able to give an answer by doing more of these detailed genetic testing? What's the diagnostic yield of these tests? So these are some really good research papers to have a look at. So genomics can provide answers for families and help with family planning, but how do we improve the opportunities so that families get more of an informed offer and consent? So we've brought together a few key tips around having a really sensitive conversation by creating a safe space and enough time to have an informed discussion with families. I always wonder if that time on delivery suite, that first 24 hours when their world has been turned upside down, is that the best time to get informed consent around genetic testing and to discuss the implications, the limitations, and what it may yield? I'm not saying it is or it isn't, but it's just worth considering and really listening and empathising with that family, because you'll learn a lot for what matters to them by having that really informed conversation. And I'm hoping by the end of this session, you'll have a bit more confidence in explaining the roles of genetics and genomics to the families, discussing their options, as I said, the implications and limitations of testing, and also going into that more personalised level around the emotional support that's required, the ethical considerations that families might have to have. And even some families think they have to pay for these tests, especially if they haven't been born in the UK and not familiar with NHS care. It's really trying to understand what their priorities are. We're very well supported in the UK with different pathways. We've got the National Bereavement Care Pathway, which really helps to reinforce the good communication is really key to fabulous bereavement care. Continuity of care is so important, and really involving the families all the way through their care. We've also got the RCOG guideline, Green Top guidelines on care of late intrauterine fetal death and stillbirth. These help to cover the maternal wellbeing tests that we look for, that look at maternal health and recurrence risk. It covers the post-mortem examination, which can provide critical insight into the loss and also for future pregnancy management. Talks about cytogenetics, which I now hope you realise is QFPCR and array, and that's offered to all parents. And the really key area of this is that parents should be providing written consent to this test. So I'm going to hand back to Emma because we need to see how Sarah's pregnancy progresses.
Sarah and John, they had been referred into genetics, aware that there was about a year waiting list, but they were pregnant again. So they had an urgent referral into genetics at about 9 weeks of pregnancy. They were seen by a genetic counsellor a couple of days later, and they consented to whole genome sequencing, and they had trio testing. What's really important to note is that testing did take about 9 weeks to return. There was no result for the 9 weeks. So that really long wait for that family must have felt like an absolute eternity. And there was no genetic changes identified in the results. And at this point, the lady was about 19 weeks pregnant. The family were cared for by Rainbow Clinic. It was an incredibly challenging pregnancy. Sarah really struggled to bond with baby, couldn't watch the scans, couldn't talk about baby, couldn't project forward to think about having baby. But really lovely, really positive news that baby was born 4 weeks ago. Baby is thriving. Sarah is doing amazing, and baby is exclusively breastfed at 4 weeks old. So the couple are over the moon. So what can we do as midwives? We can continue to provide compassionate bereavement support. We have amazing bereavement midwives that go out of their way to provide care to these families during the worst possible time that they are going through. We're running the Improve course later in the year, hopefully in Manchester. So if anybody is interested in wanting to take part in that, then please do contact me and we can update you with the dates and times as and when that comes around. We can build relationships with clinical genetics teams in the lab's pathology. We can make sure that we know how to talk through postmortem consent and truly make sure we are consenting these families to genetic testing. We can create regional networks with our lead midwives, make sure we're reaching out and knowing who is here in the area. And nationally, really important to look at the midwives and genetics and genomics networks, our midwifery networks. We've got a Rainbow Clinic network and NHS Futures page, a really good resource to share information, share challenging cases and update our skills as midwives. And what's really important to note is that practice varies massively around England, and we need to know our own policies. And what's even more important on that final note is the family voice, and we should be improving our care, taking into consideration these quotes from families and what they feel as though they need. So the key takeaways from this session is that we can get a lot of information from genomics, but there are limitations as we have discussed. It can help us provide personalised and individualised care into that next pregnancy and ensure that families really know where to go when they become pregnant again, what the plan of care is going to look like and what's going to happen in that pregnancy. It's important that we as midwives keep up to date with our own knowledge and any advancements in genomics as well to make sure we can then pass on that information to families and feel comfortable and confident having those conversations as well. And again, important just to recognise that cultural beliefs can sometimes hinder those conversations as well, and it can influence how they feel about having that genomic testing. We've put together some resources for you as health professionals, but also for families as well. So signposting areas for families, but also super important for us as health professionals to make sure we are looking after ourselves, because it is a really tough job looking after families when they have lost a baby before. One resource that I didn't put on there was Ellie's Gift and Ellie's Rainbow. So Lucy has created some mindfulness sessions, both for families and for health professionals as well. And she does a weekly session on mindfulness for healthcare professionals. So a really good one to have a little look at. And be genomic curious, have a look into these education resources and just make sure we're keeping our knowledge and our skills up to date. And we know that hopefully in the future, there's a real opportunity to potentially create a learning package that we can supply to midwives and ensure that they're feeling comfortable and confident with having these open and honest conversations with families. Thank you.